Hello and welcome to MedEd's presentation of the CNOR exam review. My name is Joyce Becker and this module is entitled Infection Prevention. The infection prevention content is really part of the content with the instrument sterilization, but because that is such a beast of material, I broke this down into two sections. So we're just going to focus on environmental cleaning, personal protective equipment, perioperative zones, and surgical attire and hand hygiene. So one of the most important tasks for the RN is to make sure that the surgical environment is clean, and we are going to talk about the environmental conditions that need to be happening in the OR. So we have various traffic zones, and this supports the movement of patients, personnel, equipment, and supplies. And there are specific apparel needed for each of these zones. The zones should be clearly marked so that people know where they are going. So the first zone is the unrestricted zone, and the only thing that you need to wear here is regular street clothes. The examples of unrestricted zones are often the locker room, the lounge areas, the pre and post-op areas, and public is restricted in this area. Only people who have family members who are involved in surgery should be in this area. The semi-restricted area, this is where hospital-issued surgical attire should be worn. The hair on the head and face should be covered. This includes support areas, storage of equipment, supplies, and authorized personnel are the only folks that should be in this semi-restricted area. The restricted area is when a surgical attire as above with a mask and eye protection is needed, and this is you're in an operating room, and the folks that are in this role are people who are supporting the patient care. One of the easy guidelines that you can think about, what's the difference between the restricted and the semi-restricted? The restricted area has open sterile supplies. So these are the environmental controls, and I provided you with a sample of some of the areas. Following these standards has proven to decrease the risk of the patient developing a surgical site infection. If there are any deviations from these norms, they should be reported to the appropriate people. Those people could be your manager, plant operations, infection control people, depending on what's the problem, who you would report to. If there's any serious variations, they may require procedures to be rescheduled, delayed, or moved to an unaffected area, or limited to emergency cases only. Sometimes the entire department may need to be closed and cleaned. They may need to do reprocessing of all your sterile instruments. And just as an FYI, the GI suite is different than procedure rooms like the cath lab or IR, because they're not doing sterile procedures, they're doing clean procedures. So they are looking at 6 air exchanges an hour. At least 2 of them have to come from the outside. The temperature has to be 68 to 75 degrees. Humidity, we're looking at 20 to 60%. And there's no recommendation for the air pressure. Sometimes people get confused about the air pressure in the room, whether it being positive or negative. So we can use the example of the operating room versus decontamination. the operating room. The air pressure is positive there. So when the door is open, the positive air pressure is pushing out so that any microorganisms, debris, anything that's in the hallway is not going into the operating room. The operating room is going to stay as clean as possible because positive, the air is pushing out. We're in decontamination area. We're cleaning instruments that have been used in cases. They have blood on them, they have body fluids on them. When that door opens up to that area, we want the air pressure to be negative. And what that means is that the air from outside is going to push into the decontamination area, keeping all those microorganisms that come off of our used instruments inside decontamination and not contaminating our hall. So hopefully that helps you understand the difference between positive and negative. So when we're talking about our environmental cleaning, ARN recommends a clean, safe environment for patients. When you are doing surgical procedures, contamination should be confined and contained within the immediate vicinity of the surgical field to the degree possible. A clean environment should be reestablished after the patient is transferred from the area of the OR. And high-touch items should be cleaned in between cases, and high-touch items are things that multiple people touch. So there's various types of cleaning, and we want to start with the preliminary cleaning. This is before you get started for your first case of the day. All horizontal surfaces are to be cleaned or damp dusted. This happens before the first case in an OR, and things that are going to be cleaned are the surgical bed, overhead lights, any room furniture and equipment that has a horizontal surface. Any equipment brought from outside the room should be damp dusted also. Interim cleaning. This happens between each case. The expectation here is trash, linen, and instruments are removed. Cleaning should begin with the ceiling and progress downward. You should use a hospital-grade germicidal agent. All horizontal surfaces are cleaned, including the patient transport devices, equipment, and OR furniture. The floor is mopped, and it is the responsibility of the RN to establish that the room is clean prior to the opening of any sterile supplies. A little bit when we're talking about mopping the floor, depending on what kind of equipment you're using, if they are using a kind of traditional mop head, that mop head may be dunked in a container of solution that has a cleaner on it, and then they clean the floor. If they've used up all of their cleaner and they want to go back into that bucket or that container that has the cleaning equipment, they need to go in with a clean mop head. If they go in with the mop head that they have just used to clean the floor, they then have just contaminated all of their cleaning solution. So we don't want to do that. Depending on what kind of cases that you're doing, you may find that you may not even need to mop the floor. Now, obviously, that's not going to be the case in a total joint because stuff gets everywhere. But if you're doing a procedure where you're doing cataract surgery, you're not getting body fluids, you're not spilling stuff on the floor. Oftentimes they do not mop those floors in between patients because they don't get them dirty. Terminal cleaning, this is done at the end of each day. Any ORs that were used need to be terminally cleaned, and that includes the scrub sinks, the sub-sterile area, a scrub utility area, hallways, furniture, and equipment. OR floors are wet for a dwell time using a wet vac or a single-use mop. And in this time, we clean from cleanest to dirty. And we are cleaning all exposed areas, including wheels and casters on tables. Sometimes I know those get missed, and it seems like, especially on back tables, those casters are magnets for little bits of suture, and they get so jammed in there that the wheels don't move. Some places, every once in a while, if they have a washer big enough, they will take the carts down and send them through the washers down in sterile supplies. Anything that's not terminally cleaned should be on a monthly or weekly schedule, depending on the use and what's going on in your organization. And this is like closets, shelves, refrigerators, sterilizers, cabinets, walls, air conditioning equipment, warming cabinets. And there should be a schedule. Sometimes Joint Commission, when they are doing their surveys, they will ask for these logs. So need to be prepared for that. Some additional points when it comes to cleaning. Any item that touches the floor must be disinfected before patient use. The floor is dirty. If an item will not withstand disinfection or is difficult to clean, you should use a barrier cover. Example, your computer keyboard. If there are any insects or vermin in your healthcare setting, they have the potential to carry pathogens that may be antibiotic resistant. So these kind of insects are a little bit more dangerous and cause for alarm. If something happens in your organization and there is a spill, not only is it an infection prevention issue, especially if there's a spill of blood, but it is also a safety risk because somebody could slip and fall on that wet. We do have some multi-drug resistant organisms in our environment, so they require an enhanced cleaning, and that's because these organisms stay in the environment longer. They're difficult to control, causes an increased morbidity and mortality, and here are the list of those drug resistance organisms. So if you have a case where somebody who is having surgery and they are colonized or had a recent infection of this type, then you want to do some enhanced cleaning. When the environment is cleaned, the people who are cleaning should wear personal protective equipment. It prevents them from exposure to caustic cleaning chemicals. The chemicals that are used should be registered with the Environmental Protection Agency, and if you are using them in an environment where you have multi-resistant organisms, you want to make sure whatever you're cleaning with will target those organisms. And dwell time is the amount of time that the cleaner needs to be in contact with the item to be cleaned, and that information is found in the manufacturer's instructions. We know that hand washing is the best thing that we can do to prevent infection. Sometimes we will use soap and water. Sometimes we will use alcohol-based hand rubs. Important to remember that alcohol-based hand rubs cannot be used with patients that either have C. diff or are suspected of having C. diff. The alcohol hand rub does not kill those C. diff spores. Surgical attire, ARN has guidelines related to this. You may, if you look at the guideline, you may notice that it is a little bit more lax. That's because a few years back, ARN created a guideline where they no longer wanted people to wear skull caps in the OR. When they were pressed with that, they didn't have any evidence. So now they're very careful. They make sure they have evidence before they recommend such guidelines. Oh, one of the things on the exam that it's kind of a classic question. When you are getting dressed with your surgical attire, what is the first thing that you put on? And that would be your hat or your covering for your hair. And the rationale behind that is the reason why we cover our hair is to prevent hair and any cells from our scalp falling down on our scrub top, and then that can fall into the patient. So that's why we want to put that hat on first. The shirt should be tucked into the pants when you're wearing your surgical attire. Some places people do wear scrub dresses, but if they are going to wear a scrub dress, they have to wear it over pants. Personal clothing can be worn under the attire. ARN does not have a guideline related to that, and that's really up to your facility. For safety purposes, you should not wear your ID tag on a lanyard, and your ID tag should be cleaned on a regular basis. Most perioperative nurses do not walk around with stethoscopes around their neck. That would be another problematic way to have your stethoscope with you. If you are going to have your stethoscope with you, it should be in your pocket, and it should be cleaned between patient use. Hats and hair, you don't save worn hats, jackets, or scrub. So you need a clean one every day. The goal for your hat is to completely cover your hair and scalp. And if somebody is working in an area where they're preparing or packaging instruments, their beard also must be covered. Since we are out of the pandemic and our supplies have returned to normal, we are changing our masks in between cases, and a mask does not hang down around your neck in between cases. Eye protection should be cleaned in between cases, and then shoes, you do not have to wear shoe covers if your shoes are dedicated for use within the OR. If that is the case, then you would just use shoe covers to prevent contamination from liquids that you might be doing. Standard precautions. This is our goal is to treat everybody the same because we are uncertain of their infectious status. So we use good hand hygiene. We select our PPE based on the anticipated exposure. We handle our sharps in a safe manner, and we use effective cleaning procedures. Sharp safety. In 2000, there was a Needle Stick Safety and Prevention Act that came out. It was a federal act, and they found that there was a 31.6% decrease in injuries from needle sticks in a non-surgical setting. In that same time frame, they found a 6.5 increase in surgical settings. There's really no evidence for why that happened, and most people say that it is not really an increase in occurrence, It's more an increase in the reporting that was happening. OSHA requires a exposure control plan for patients who get exposed to bloodborne pathogens. There should be an annual review of that control plan so that the employees know how to keep themselves safe. One of the concepts that may come up on your exam is the issue of hierarchy of controls. And this pyramid, the most effective way to manage a item that may cause injury in the environment is most effective way is at the top of the pyramid in blue, elimination. And then as we move down the pyramid, you get to the bottom, and that is the least likely method of control that's going to help the situation. So just understand that elimination, you're physically removing the hazard. Let's say we're talking about needle sticks. So we would physically remove, there would be no needles in the OR. That's a possibility. We could probably decrease most of them, but I don't know that we can totally eliminate them. Substitution, replace something for that hazard. So one of the things is that we do replace with blunt needles, and sometimes we replace with little plastic kind of things that aren't going to stick you, but you can put them into IVs and push medications in. Engineering control would be isolate the people from the hazard. It's pretty hard to do that when it comes to needles in the OR because we actually use them. Administrative controls change the way people work. That's what the nominal and safety zone is, where people have have two people's hands on a sharp at the same time. So if a surgeon is done using a suture needle, they'll have it in the needle holder, they'll put it on the back of the Mayo stand, they'll set it down and say needle back, and then the scrub person picks it up. So there's only one hand on it at the same time. And then PPE, you try to protect the worker with personal protective equipment. The best practice for sharps disposal is to use a puncture and leak resistant container. You want to remove sharps before you decontaminate the instrument. That means take the blade out of the knife handle before you send it down to sterile processing. And perioperative RNs should be the role model for others. Follow the regulations, wear the PPEs. If there is a injury, report it timely, get treatment, and then also consider being immunized against hepatitis B. A lot of organizations provide that for their caregivers. So those are our standard based precautions, and then we also move into some transmission based precautions. And these are used when you know a patient has a known or suspected infectious disease. This is in addition to the standard levels of precautions, and this is based on how does that pathogen be transmitted to the person or from the environment. Also with this transmission-based precautions, because we have become such a mobile environment or a society, we are asking people about recent foreign travel when they enter the healthcare system. So we have contact precautions. This is direct or indirect patient contact. Direct is the passage between two people. Indirect is when there's contact with some contaminated surface. Airborne pathogens, this is when the pathogen is small. It's 5 micrometers or less. It stays suspended in the air, It's transmitted by sneezing, coughing, or talking. And what we want to do to prevent this microorganism from affecting other areas of the hospital is to use a negative pressure room. Droplet precautions, the pathogen is greater than 5 micrometers. This is transmitted the same way with sneezing, coughing, and talking, but because the microorganisms are bigger, they have a tendency to settle within 3 feet of the source. So the distance from the source is another element of personal protection. Here you have a slide that has the various diseases, how it is transmitted, and what is the required PPE. I'm sure this will be helpful to you. And that concludes our information on infection prevention, and we are at the end of this module.